Good afternoon, everybody. My name is Juan Bustillo. Most of you, I think, know me. I'm faculty here at the university in the Department of Psychiatry. I've been here 28 years. My work has really focused on understanding the pathophysiology and the treatment of schizophrenia and other psychotic disorders. And I'm very glad to present to you an update on the psychosocial and pharmacological treatment of schizophrenia. So these are my disclosures. Okay. And this is an overview of my presentation today. So I'm going to be starting with just briefly defining the problem that we have as clinicians when we approach patients who turn out to have schizophrenia. And then I'm really going to focus on four stages of the illness that really help us define the type of encounter and clinical approach that we have for patients with schizophrenia. How we handle the first episode of psychosis, how we handle recurrence of psychosis, which happens to 90% of patients with schizophrenia, unfortunately. How then we handle the patients who have persistent psychosis, despite our best available treatments, and that's about a third of patients. And finally, what is available to help patients who have persistent functional impairment. Of course, sadly, about 80 to 90% of patients with schizophrenia do not return to their previous level of functioning. And I'll end with some summary and recommendations. And I hope that we'll have 10 minutes or so for questions at the end. Okay, so I'm not going to spend too much time on definitions. Most of you know what is the definition of schizophrenia. Schizophrenia is a chronic serious mental illness in which patients have psychotic symptoms. Psychotic symptoms are major impairments in reality testing characterized by four types of symptoms. The ones that we see most often and the easiest to identify are delusions and hallucinations, and a couple others are less frequent and are disorganized thinking and disorganized behavior. Although psychotic symptoms are necessary for this diagnosis of schizophrenia, they are not sufficient. And furthermore, psychotic symptoms are not only seen on patients with schizophrenia. And that's sort of what I try to illustrate here with this ellipsis, in which you can see that there are other diagnoses that we frequently encounter in the clinic that can present with psychotic symptoms, like bipolar disorder, unipolar depression. And schizoaffective disorder is a sort of intermediary condition that is not well studied, but in which patients have psychotic symptoms. They must have psychotic symptoms, and they must have also clear major mood episodes. The other part of the diagnosis of schizophrenia is that schizophrenia is a chronic illness with major functional deterioration. And that's what's depicted here. Most patients that we end up seeing in the clinic develop psychotic symptoms in their late teens or early 20s, a little bit later in females than males, but most patients will have what's called a prodrome, which is a period of months or years in which retrospectively families identify or recognize that the patient has been deteriorating in their ability to function before they have psychotic symptoms. And this in addition with the prolonged deterioration of function following the first episode of psychosis is what Kreplin identified as dementia precox at the turn of the last century. However, it is important to remember that not all patients with schizophrenia have a major functional deterioration. Not all patients have a dementing kind of course. Now, this is a little bit of a busy slide, but I think it's useful because it identifies a lot of what we know about functional impairment in schizophrenia, which is an important outcome that we're gonna identify what treatments are available for this. And this is a study done in Italy in which a large group of patients with chronic schizophrenia were followed for 4 years. They were followed naturalistically. And with the goal of identifying predictors of these functional outcomes. And the functional outcomes are on the sort of the boxes to the right. Everyday life skills, the ability of the patient to dress himself, feed himself, live somewhat independently, work skills, and interpersonal relationships. What predicts this? And in this big sample, they found, well, not surprisingly, what you have in this sort of the middle column, that everyday skills were predicted by everyday skills at baseline, and work skills the same, and interpersonal skills the same. What was more interesting was what other characteristics assessed at baseline predict functional impairment. And let me just tell you that the arrows here, the strength or the thickness of the arrows represents the strength of the relationship. How robust is the relationship? The arrows that are continuous represent a direct relationship. So increase in one box represents increase in the outcome box, and the dotted arrows represent inverse relationship. So you here see that, for example, delusions and hallucinations, the so-called positive dimension, 4 years before follow-up, had a very small negative relationship with work skills. So the more psychotic the patient was at baseline, the worse the work skills 4 years later. Disorganization, here they separated psychotic symptoms between delusions and hallucinations, positive dimension, and disorganization dimension, which involves disorganized thinking and disorganized behavior, a less common set of symptoms. However, this set of symptoms has a much stronger inverse relationship with social cognition at baseline, and social cognition is one of the strongest predictors of both work skills and interpersonal relationships, which is excuse me, let me go back, which is what we see here. Disorganization inversely related to social cognition. Now, social cognition is strongly predicted in interpersonal relationship and work skills. Furthermore, negative symptoms, avolition at baseline, inversely predicted in a relatively strong way interpersonal relationships, and neurocognition at baseline, the ability to remember, to plan, to attend, strongly predicted both social cognition and everyday life skills. So in general, what this study illustrates is something that we've known for a long time, but this study documented this prospectively, that neurocognition, especially social cognition, and negative symptoms are the strongest predictors down the road in function. All right, so now we get to the meat of the presentation. We're going to talk about how do we approach the patient in their first episode of psychosis. So differential diagnosis is absolutely critical because, like I said, psychotic symptoms are not exclusive of schizophrenia, and the differential diagnosis matters. It matters if the psychosis is due to a bipolar disorder or a major depressive disorder, or primarily due to substances or due to schizophrenia. And in this regards, getting a detailed history from the family is critical. I'm not going to go too much more into that. So an early identification is absolutely essential. That's because of the relationship between untreated psychosis and outcome. And that's what's illustrated here in this slide. So this is from a meta-analysis looking at a lot of studies that try to assess the relationship, the strength of the relationship between duration of untreated psychosis and various outcomes. So you have on the first column the outcomes, yeah, that were assessed in this meta-analysis, and you have negative symptoms, positive symptoms, that's the same as psychotic symptoms, overall functional outcomes, social functioning, vocational functioning, time hospitalized, and you see that there's a very clear relationship between the duration of untreated psychosis and these outcomes. The longer the patient had been psychotic before they got treatment, the worse these patients did down the road. So that is a clear justification to do as much of an effort as we can to bring patients to care as soon as possible. The next step, once we have made a diagnosis and we have the patient in the clinic, of course, is selecting antipsychotic medication. Antipsychotic medication is the mainstay of the treatment for schizophrenia. It is not the only treatment. And antipsychotic medications are, by definition, those drugs that have established efficacy for the treatment of psychotic symptoms. All these drugs, with one exception that we'll talk about later, are dopamine D2 blockers. And the efficacy of for psychotic symptoms is usually established and apparent in a matter of days or weeks. Most of these other drugs have also proven themselves efficacious to prevent relapse of psychosis. And these are studies done in a time frame of months, sometimes years. Now, what drugs do we use? So we have over 20 antipsychotic medications. In principle, we can use any antipsychotic medications. There's only one exception of an antipsychotic medication that is more effective than others, and that is in a very specific context and not in the context of a first episode psychosis. So we can use any antipsychotic medication except clozapine, olanzapine, chlorpromazine, and thioridazine, and that's because of the side effects, significant side effects with these 4 drugs. So we select an antipsychotic medication really based on the side effect profile. Now, before we get into the broad side effect profile, let me spend one slide talking about the concept of atypicality. What is an atypical antipsychotic? So this was a term that was very popular 20 years ago. It's sort of been drifting, but the main concept is useful because antipsychotics, some of you may remember, used to be called neuroleptics. We don't call them neuroleptics anymore. We don't call them neuroleptics because of the concept of atypicality. A neuroleptic effect is a medication that causes extrapyramidal side effects. And they were called neuroleptics because for decades, it was assumed that in order for a drug to be an effective antipsychotic, it had to cause neurolepsis. It had to cause EPS. With the introduction of clozapine in the 1960s, we found that that is not true. So the robust concept of atypicality I would propose is the following: is a drug that is as efficacious, for example, as haloperidol, but as neutral in terms of EPS as placebo. And not only that, but that these equivalencies between the prospective drug and haloperidol and placebo are manifested and apparent across the whole recommended dose range. This makes the concept of atypicality operational and much more stringent. So if you use this concept, you will see that many of the drugs that are available have not been proven themselves as strong, robust atypicals. And this is an example that is in the literature, and I've chosen it on purpose because it's a drug that is not available in the United States. and it's Certandol. And this is the two panels that I'm showing is from a publication in the American Journal of Psychiatry a couple decades ago. And what you have here is the true a concept of atypicality illustrated. So this is a very interesting, very difficult study. That's a randomized control study in schizophrenia with an acute exacerbation with 7 arms. Patients were randomized to 7 arms. 1 arm was placebo, and the other 3 arms were Certandol at 3 dosages and haloperidol at 3 dosages. And what you see in the left panel, the y-axis is the change in symptoms. And you see, fortunately, in this study, there was a very small placebo response. So there was almost no change with placebo. However, there were meaningful and reliable improvements with Certandol in the black bars across all 3 dosages. And they were very similar to haloperidol. We know haloperidol is a very good antipsychotic. Now, however, in order to really demonstrate the atypicality of Certandol, you have to look at the risk of EPS. And on the y-axis, on the right side panel, you see the percentage of patients who had EPS. And you see that for placebo, in white, it was about 20%. And in black, you see the percentages across the 3 doses of Certandol. And you see that haloperidol is much higher across the 3 doses. This is a true atypical pattern. So remember that when you start looking at new drugs that come through the pipeline that are, presented as novel and worth the cost. Now, these antipsychotics, I've said they've been shown efficacy. This is data that is useful because it's from CATIE, the largest effectiveness study done on antipsychotics. About 1,600 participants with schizophrenia, with chronic schizophrenia, randomly assigned to 5 drugs. One of them, perfenazine, is a first generation or neuroleptic. Okay? And the other 4 were so-called atypical antipsychotics. 20 years ago, these were called atypical antipsychotics. And the expectation we had is that the atypicals are going to do so much better than perfenazine. What you have on the right side is the proportion of patients on the y-axis who discontinued the medication for any reason. And you see the strength of this study is that it was a long-term study, up to 18 months. And you see in the red, you have olanzapine, patients randomized to olanzapine. In the dotted black line, perfenazine. And you see that really there was no meaningful differences between perfenazine and the other drugs. Olanzapine was a little bit better than quetiapine and risperidone. What was also striking is the majority of patients after 6 months had discontinued the medication that they were assigned to. So what this study showed is that the idea that the new drugs, the initial atypicals, were going to be more efficacious than the old drugs was not true, did not pan out. Okay, we're still moving forward with choosing the antipsychotic that we're going to use for our patients in their first episode of psychosis. Like I said, this should be done based on the side effect profile. And you have on the first column a group of drugs that are now called second generation antipsychotics. They're not called atypical antipsychotics because many of these, probably most of them, will not meet a stringent criteria for atypicality. And at the bottom, you have the so-called first generation agents. Striking the first 3 columns of side effects, they define what we call as metabolic syndrome. And of course, the second generation agents in general have a very significant problem with metabolic syndrome. There are some that are more benign. For example, aripiprazole, lumateperone. Okay, they only have 1 plus sign for weight gain and glucose abnormalities. And then in the following 4 columns, you have the side effects that come under neurolepsis or EPS. And you see that many of these agents, sadly, the second-generation agents still have significant akathisia, not as bad as flufenazine and haloperidol, fortunately. Again, lumateperone is one of the most benign, like iloperidone. But these agents still have significant tardive dyskinesia, like you see further down on the column for tardive dyskinesia. Many agents have two plus signs. And then they have a variety of other side effects like sedation, anticholinergic side effects, orthostatism, etc. Okay, now this is something very exciting, and many of you might have heard about this agent, which is called xanomeline trospium. Okay, and this drug just became available over the last month and a half. And this is a drug that is exciting because it's the first drug that doesn't directly target dopamine. It does not block dopamine D2 receptors, unlike all the other agents. It is a cholinergic agonist specific to muscarinic 1 and 4 receptors, and it is thought to had its efficacy through modulating presynaptic dopaminergic terminals in the striatum. The agonism of the M1 and 4 muscarinic receptors turns down, apparently, the release of presynaptic dopamine, resulting in a less dopaminergic output in the striatum and reduction in psychotic symptoms. Now, because the drug goes throughout the whole system and it has cholinergic agonism in the whole body, the maker of the drug combined xanomeline with trospium, which is a peripherally acting broad anticholinergic agent. So the trospium blocks the cholinergic agonist effects outside of the brain, but the trospium does not get into the brain. The xanomeline gets in the brain, stimulates cholinergic receptors, and tunes down the release of dopamine. And this is from a very recent paper published in JAMA, where you see on the right panel a clear beneficial effect on positive symptoms in patients with acute schizophrenia. All right. So though that's what we need to keep in mind for dealing with the patient in the first episode. We'll come around and talk about how we now integrate some other treatments into the first episode towards the end of the presentation. But now let's go back. Let's go to the next type of encounter that we clinicians fail. 80 to 90% of patients will have a relapse of psychosis, even if they are compliant. The first thing you think when someone has relapse in psychosis is compliance. And non-compliance can be of 2 types. One is overt non-compliance, and the other one is covert or hidden non-compliance. Covert non-compliance is in patients who have typically very poor insight, and they hide the fact that they're not taking medicine. Overt non-compliance is in patients who are more cognitively impaired. They don't remember to take the patients. And of course, there's many patients that have a combination of overt and covert non-compliance. Suspecting non-compliance is absolutely essential. And the treatment is usually, the next step of treatment is long-acting antipsychotic medication. Other aspects, 2 other important psychosocial interventions for recurrent psychosis that we'll talk about is family therapy and assertive community treatment. So, going to family therapy. Many of you have heard the term expressed emotion. And this was a construct defined by Brown in England in the 1970s. Brown studied families of patients in their first episode of psychosis. And he interviewed the families while the patients were in the hospital and rated them on a variety of comments that the family members made. It turned out that the families that rated high on hostile, critical, and over-involved comments towards the patient, it was in the patients who returned to those families were twice as likely to relapse in the following year compared to patients who returned to families who were rated at baseline as low in expressed emotion. So that's the relationship between expressed emotion and relapse of psychosis. It's very important to remember that this is not a relationship that implies that psychosis or schizophrenia are caused by families. You may be surprised that I even bring that up, but for some of those older people, in the 60s, especially in the United States, there was a big push in some academic centers to support the concept that some families had schizophrenogenic mothers that because of their coldness and their distance and their impairment, psychological impairment, would basically cause some of their children to develop schizophrenia. Obviously, there's currently absolutely no evidence for this. And it's important to remember that the relationship between high expressed emotion and relapse is not about the cause of schizophrenia, it's just about relapse, and that relationship is not specific to schizophrenia. Indeed, we find that relationship across many psychiatric conditions and many medical conditions. Children with asthma, epilepsy, illnesses in which the person is susceptible to stress if they live in an environment, not just the family, in which the environment that is highly critical, those illnesses will tend to be less stable. However, this was an important association, an important theoretical formulation. Because it led to several types of interventions being developed in the 70s or 80s to help families reduce the stress for their children with schizophrenia. And this is from a meta-analysis from Cochrane. And you see that for studies that involve at least 5 sessions of family interventions, there was a 2-fold reduction in risk of relapse for patients who reside in that family. And these are some of the take-home messages from this literature for family interventions. And we can all do this with most of our patients who reside with family members. It's important to educate the family that schizophrenia is a brain disorder with genetic, perinatal, and environmental risk factors, and it is not due to poor parenting. Freeing the parents from the terrible stigma that they might have caused schizophrenia is critical to help patients get better. It's important to further educate the family that some of the negative symptoms are symptoms of the illness and they are not laziness, and to explain that some of the psychotic symptoms are distressing symptoms that are likely to improve with treatment, and avoid stigmatizing terms like craziness. Important to teach family members how to recognize early warning signs of relapse so that they can inform the treatment team that the patient is at risk of relapse. Explain the importance of medication adherence to the family. Educate the family about the high comorbidity of substance use in schizophrenia. About 45% of patients with schizophrenia will have comorbid substance use. And foster optimism with the family. Schizophrenia is a heterogeneous disorder, and good outcomes like we'll see are possible. All right. Then we move on to compliance in terms of addressing recurrent psychosis. And this is from a study done in Finland, a very large study following up in patients with the first episode of psychosis. What is the risk for rehospitalization? And what Tihonen and others found that the risk increased with time, and only 45% of patients continued treatment beyond 1 month. So compliance, poor compliance is a fact in probably the majority of patients with schizophrenia. We have to suspect it. We have several options in terms of long-acting injectable antipsychotics. These are some of the ones that we have available. I'm not going to get into these. Suffice it to say that for us as clinicians, it is critical that we do not start an injectable long-acting until we are convinced that the patient will tolerate the drug. And the last available approach that we have to prevent recurrence of psychosis is assertive community treatment. And most of you know that we have a program of ACT as part of our, in our department, the ACT program led by Dr. Bonham. It is a team-based program with, and the characteristic of ACT is that the locus of care for the patient is in the community. Very different than what we provide to most patients, where we ask and expect them to come to the clinics for care. The goals of ACT are to maintain safe residency in the community, compliance with prescribed medications. That's what medications often are taking to the patients at their place of residency in the community, and to minimize utilization of emergency psychiatric and medical services. The main indication is for patients with repeated hospitalizations or homelessness. And this is not just for patients with schizophrenia, but patients with serious mental illness like bipolar disorder, severe personality disorders. And the characteristics of these patients, more specifically, are patients with severe illness, like very persistent delusions or hallucinations, poor insight, cognitive impairment, poor compliance, comorbid substance abuse, and limited family support. Efficacy for ACT has been repeatedly documented, and this references for a meta-analysis that showed that ACT had 37% better than standard of case management services for patients with serious mental illness who are homeless. So ACT works. We need to keep it in mind. We need to use it. Then we go to the next stage of treatment or type of encounter for our patients with schizophrenia, which involves about a third of patients who will have persistent delusions, hallucinations, disorganized thinking, despite being compliant with an antipsychotic medication and despite refraining from using substances. So it's a third of patients. And the main treatment that we have for this group of patients is clozapine, which was the first and true atypical antipsychotic. And this was ascertained for the first time in a study, the landmark study by John Kane, published in 1988. And this study enrolled patients with schizophrenia who were in hospitals, and had been in hospital for months or years, who were treatment resistant with 3 previous failed trials with so-called typical or neuroleptic drugs. And these were 3 previous trials ascertained retrospectively, but also all patients had to fail a prospective trial of haloperidol for 6 weeks and up to 60 milligrams of haloperidol. We would never use 60 milligrams of haloperidol now. In that study, many patients did not reach 60 milligrams. But that was how stringent the criteria was to make sure that these patients indeed were treatment resistant. It was a randomized controlled inpatient trial for 6 weeks. Patients were randomized to clozapine or chlorpromazine, and 30% of patients improved in psychotic symptoms versus only 4% in chlorpromazine. Huge finding. Always encourage the residents to read this paper because it is indeed a landmark paper. There's been many other studies that have documented the superiority of clozapine in other settings. So, again, you don't need to wait for the patient to have failed 4 or 5 or 6 trials to be able to start clozapine. This, again, is from the CATIE study. In this case, it's the phase 2 trial of CATIE. So patients who had discontinued the assigned medication in the phase 1 were then randomized to take one of the other antipsychotics that they didn't try, or clozapine. It was randomized, but it was open label, so it was an effectiveness trial. And I draw your attention to the top right panel, which shows on the y-axis a proportion of patients without an event, so who have not failed in terms of effectiveness, and on the x-axis time, again, up to 18 months. And what's striking, of course, is that the green line for clozapine stays at the top, at the very top, is almost flat. That means patients had efficacy for clozapine, and the other patients, it had much lower efficacy. So clozapine clearly has superior efficacy in patients that have treatment resistance to previous antipsychotics. Now, should we try clozapine early on? Why wait if it's a better antipsychotic? Well, Lieberman tested this hypothesis in another really important study in first episode schizophrenia, in which patients were randomized to clozapine or chlorpromazine. This study was done in China. It's a full randomized control efficacy study. Patients were blinded and patients were followed for a year. And what was clear is that patients on both treatments improved similarly. There was no advantage to clozapine in this group of patients. We don't understand what's the case, why this is the case, but clearly clozapine is only indicated when a patient with schizophrenia has failed, clearly failed, at least one antipsychotic agent. So let's spend a little bit of time in terms of the strategy and mechanics of starting patients on clozapine, since this is such an important and underutilized therapeutic avenue. So first of all, the indication is psychosis that is pervasive and has persisted despite a previous good trial with an antipsychotic. Poor tolerability is not an indication for clozapine. It used to be an indication. Patients who had tardive dyskinesia and had schizophrenia, that was an indication for clozapine. It is no longer. Just pervasive psychosis that is treatment resistant. Critical, we do not rush to start anybody on clozapine. It is absolutely essential that we educate the patient and the family, because as we tell patients, you're going to probably feel worse before you feel better when you start clozapine. That's because clozapine, it has a very broad dose range, and because it requires very slow titration due to a lot of side effects. So nobody should be rushing to get someone on clozapine and take them to the therapeutic dose quickly. You have to be able to get a variety of labs to check for risk of agranulocytosis, metabolic syndrome, and cardiomyopathy. And we'll talk about these later. In terms of the logistics, we have some good news. Many of you are aware that the FDA in the last couple of months recommended to discontinue the requirement of a national registry for clozapine in the United States. That's because clozapine is underutilized in the United States, and keeping the registry just makes it less likely that patients and providers will decide to try clozapine. Still, there's a lot of logistics in terms of finding a pharmacy that manages clozapine, a lab, and transportation to the patient to come and see you for the first 2 or 3 months, when you should be seeing the patient every week if you start the patient as an outpatient. As I mentioned, titration with clozapine is very slow. We typically in our clinic give 12.5 milligrams test dose. Some clinics give 25 milligrams, and we titrate about 100 milligrams a week. And we cross-taper with the variety of other antipsychotic drugs that invariably patients are taking by the time you offer clozapine. It's important to be patient. The trial is going to take at a minimum of 3 months or sometimes up to 6 months. And you need to be prepared to discontinue clozapine, since in up to 50% of patients, the drug will fail. Okay, now we go on to tolerability of clozapine. Why is it that clinicians are uncomfortable prescribing clozapine? And here I illustrate with 3 different colors the general type of side effects. And here you have at the very top, the most serious side effects, agranulocytosis, which is rare, and we monitor with the CBC, seizures, which is dose-related. It's not so rare. So if you are taking a dose of 300 milligrams, about 3% of patients will have clozapine, will have seizures. If you're taking 700 milligrams, about 7% will have seizures. And we treat that with valproic acid. It is not a contraindication for clozapine. And a very rare but very serious complication that occurs in the first 3 months of treatment is myocarditis. You need to suspect it. Now we check troponin and C-reactive protein every month for the first 3 months. Then we have some very common, serious but not life-threatening side effects, which are metabolic syndrome. We're not going to get into this. You've heard a lot of presentations on metabolic syndrome. We should try to start patients on metformin when they start clozapine, because so many of them will develop weight gain, and metformin is efficacious in preventing the weight gain or reducing the risk of weight gain. Constipation, again, very common early on, affects the great majority of patients. We've had at least 5 patients that have died from complications of constipation over the last 30 years in our clinic. They develop ileus and then septicemia. So it's very important to treat this with stool softeners. And then there's a variety of other side effects that are unpleasant, very common, like drooling, orthostatism, tachycardia, sedation. If a person has chronic tachycardia above 110, you should treat the patient with atenolol chronically to prevent a dilated cardiomyopathy, which is very different than the acute myocarditis that happens in the first 3 months. Finally, a very interesting and frequent side effects is obsessive compulsive symptoms. These occur for reasons we don't understand rather late in the course of treatment, 6 months, a year, 2 years later, and it's very common. So if you look for it in patients that have been chronically treated with clozapine, you'll find it in as many as 30% of patients. And these OCD looks just like OCD, responds very well to treatment with serotonin reuptake inhibitors. All right. What else is available for persistent psychosis? Cognitive behavioral therapy has been developed for persistent delusions or hallucinations in schizophrenia. The premise is to engage the patient in a logical examination of the maladaptive aspects of the delusions or hallucinations. The patient and the therapist work collaboratively to develop more rational interpretations and adaptive behaviors. It sounds simple. It's not simple. Therapists have to be trained on this specific technique. We don't have much access to this kind of technique, unfortunately, in our clinics. But CBT for persistent delusions or hallucinations has been found to be effective. I draw your attention to the third row for this meta-analysis by Turner, in which patients randomized to CBT were compared to patients randomized to other conditions. The outcome measure was positive symptoms, specifically delusions or hallucinations, and you see a small effect size of about 0.2, but this has been replicated enough that we have confidence recommending it. Finally, patients that have persistent psychosis, they should be tried with electroconvulsive therapy. And this is the study by Petrides, in which patients on clozapine who have persistent psychosis were giving ECT, and in orange you saw a clear advantage. We're fortunate to have a very good ECT service in our program led by Dr. Abbott. Next, and I have included this under persistent psychosis, although it doesn't truly belong here, is the recent availability of vesicular monoamine transporter inhibitors, drug like valbenazine, that have been found to be effective for tardive dyskinesia. And here you have an example. There's a couple of these drugs. This is for valbenazine, for tardive dyskinesia. And on the y-axis, you have change in dyskinesia. As the x-axis, you have time. And this is a controlled trial for patients with tardive dyskinesia. In orange, you have placebo. And in green, you have 2 doses of valbenazine, with clear and robust improvements after week 2. So that's something that we all need to be familiar with as clinicians and know that is available and it is safe to use in combination with most other antipsychotics. Then we go into functional impairment, the final stage where we encounter patients. And we need to keep in mind that the majority of patients will have functional impairments, and social skills trainings consists of behavioral training focused on specific situations, problems, and activities. For example, the patient who has poverty of speech, a very common negative symptom, the therapist will encourage them to look at them, answer questions, elaborate more and more their answers, use paralingual manual and gesticulations to communicate, and eventually that these skills will generalize in the community. Again, this is from the meta-analysis by Turner, and I draw you to the 4th row, where social skills training in this meta-analysis were compared to all the other treatments available, and this was for negative symptoms. And again, you see a mild effect size for social skills training. We have social skills training available as part of our psychosocial rehabilitation program. An alternative is not to train the person on primary behavioral skills, but take the patient and put them in the setting where the main outcome takes place. In this case, work. So vocational training is very important for most of our patients with schizophrenia, since less than 20% will be in competitive employment. And there are 2 varieties of vocational training: shelter employment, where the job is owned by a rehabilitation agency. This is a traditional approach. And a more current approach is called supported employment, in which the therapist helps the patient find and maintain employment in the competitive job market. Supportive employment has been found repeatedly to be more efficacious than sheltered employment. This is from a meta-analysis that showed in randomized controlled trials, supported employment is 3 times more effective than sheltered employment in terms of attaining and keeping competitive employment. So this is, again, something that is available to us through our PSR program. And these are some of the key elements of supported employment. I don't have time, so I'm going to move on. And this is a sort of going back to the beginning of the first episode, psychosis, how we integrate available treatments to improve outcome in first episode patients. And this refers to the RACE study, The RAISE study was done about 8 years ago. We were fortunate to have a site for the RAISE study that was led by our own Steve Lewis. And the RAISE study compared a package of care that was called Navigate versus treatment as usual across centers in the United States. It was a controlled study, but it was an effectiveness study. So it wasn't a blinded study. And the experimental condition, the Navigate condition, included a family clinician who provided family therapy for patients, for their families, a prescriber. I hate this term. This includes every clinician that can prescribe antipsychotics, supportive employment, individual resiliency training by a clinician, by the therapist in the program, a peer support specialist, and case management. And I'm not going to go too much into this, but these are the main results from the RAISE study. And on the left panel, you have the y-axis quality of life. And on the x-axis, you have time, and you see a nice interaction, not very strong, in which the red line is for the group assigned to Navigate, the experimental treatment, and that line is steeper than the blue line, the standard of care, which suggests that with time, patients on Navigate improve more in their quality of life. And on the right side, you see a slight interaction also with further improvement in total symptoms for the patients assigned to Navigate. Okay, so now we have made it to the end of our presentation. And let me give you just the last 3 slides with recommendations. And then hopefully we'll have a little bit of time for questions. So for patients with schizophrenia, early identification of the patient is absolutely critical because we want to reduce the duration of untreated psychosis. And the mainstay of treatment is antipsychotic medication. You want to select the drug that is best tolerated, that has the least amount of metabolic risk, the least likelihood of Parkinsonism, the least likelihood of other side effects, and the easier to take. You want to use the lowest effective dose. This is maximized by having frequent visits with the prescriber. You want to seek a true atypical effect, as I described before. For sure, you don't want to have to give anticholinergic medicines due to EPS to patients long term. You need to change the medicine if the patient is having persistent EPS. You want to prevent metabolic syndrome, get comfortable using metformin, and be prepared that about 10% of patients may not need long-term antipsychotic treatment. Family psychoeducation is absolutely essential. You do not need to be trained in recognizing and reducing expressed emotion. Simple family psychoeducation can go a long way. For most patients, you need to refer them to PSR to do social skills training because they will have functional impairments that do not improve when the psychosis get better. You want to refer patients for supported employment through PSR. You want to address substance use because it increases relapse, and you want to suspect non-compliance. When non-compliance is likely, you want to offer long-acting injectable antipsychotics. For patients that come for their first episode, if the onset of the illness has been insidious, they've been sort of losing function for years, and then they come for treatment, those are the patients that most likely are going to be very disabled, and it may be worth referring them early for disability application. Think about clozapine. Use clozapine early on for patients who fail 1 antipsychotic, at most 2 antipsychotics. Think about ECT, can make a big difference for many patients. CBT for persistent delusions and hallucinations, when available, should be considered, and ACT for homeless patients and frequent relapsers. finally remain hopeful. Schizophrenia is a chronic illness. You want to be available for the patients and their families in the long term. You want to build a therapeutic relationship and be there for the patients because there are new things available. Xanomeline is available. It may make a difference for many patients, and there's always other drugs available in the pipeline. And I'll stop now, and I'll take any questions if we have a little bit of time. Can you hear me? Hello?
We're here, Dr. Bustillo.
Oh, okay. Okay, so Abby, anybody that has any questions, I'm looking for posted questions, but if anybody has a question, Davin, I'm looking at you. Do you have a question?
No, but I just appreciate your talks always. They're so informative and they cover so much both important basic material as well as advanced material. So thank you, Juan.
You're welcome. I see here that Avi posted social rhythm therapy is evidence-based for bipolar 1. Any efficacy in schizophrenia? I don't know, Avi. I really don't know. What's social rhythm therapy? What is it? What is it about? I hadn't heard about it.
Oh, so social rhythm therapy is used to look at circadian rhythms and interactions during the course of the day, looking at sleeping habits, eating habits, but also looks at interpersonal relationships, like if you have an adolescent, how you get them out of bed without having a fight. There's also a version of interpersonal and social rhythm therapy that deals with both depressive aspects of bipolar as well as manic episodes. There's also a trial of interpersonal social rhythm therapy in people with schizophrenia who present with depressive symptoms that's effective. I was just wondering, because it's often used for interpersonal reactions in the home setting, wondering if that might be a supplement to what's being given for families.
Well, that's very interesting. I appreciate it. I was obviously I'm not familiar with this kind of therapy, and I'd be looking forward to hearing looking into it and learning more about it. There's a question by Peter. Any idea when xanomeline will be released? Well, Peter, so our own Rachel Rose, third-year resident, was, as far as I know, the first clinician in the center to use xanomeline. She has a patient that she just started. She actually will be presenting grand rounds for us in April on xanomeline for schizophrenia. So stay tuned because we'll hear more about xanomeline. It is available, so you can get it now. Anybody else? Any other questions?
Hi, Juan.
Yes, Debbie. Hi,
Debbie
how are
here.
you?
I'm wondering if you can give me a resource to help support patients with using CBT to help support managing chronic delusions.
I don't have a resource, right now available, but no, I don't have a resource. I have not been able to find someone here in the Albuquerque area. I bet there is someone who has been trained in CBT for delusions or hallucinations. Does anybody know of someone? A therapist? Gerardo, do you know of anybody that has been trained for CBT for delusions and hallucinations? Yeah. All right. Well, it's 2:03, so we'll stop now, and thank you very much. Have a good weekend.